Hi, and welcome to our show. My name is Dr. Kat Kesty, and this is Dr. Chelsea Kesty. And today we're going to be talking about using lasers to treat precancers. So precancers, also known as actinic keratoses, are exactly what they sound like. They are signs of sun damage and DNA damage on your skin that a certain percentage of them will turn into skin cancer, squamous cell carcinoma. So it's very important to treat precancers. And also, once a patient has precancers, to discuss with them ways to decrease their chance of getting skin cancer in the future. So let's dive right in. Dr. Kesty, a patient comes to you with actinic keratoses. What lasers are you using on them?
There's a variety, and I think we need to take one step back and say, let's do an evaluation, because if it's one precancer, that's a different story to than if it's 50 precancers. So first of all, we need to evaluate what is that number. I tend to use a spot treatment if it's 1 or 2 or less than 5. And that spot treatment means I'm doing an ablative erbium, which is a 2 millimeter or 4 millimeter spot. And I'm taking the skin down to usually just under, still in the epidermis, so lower risk of scar, but into that first layer of epidermis. So that's kind of where I treat to as far as that precancer.
So that would be kind of 1 to 5 precancers. What about more than 5?
Then you're talking about something like a field therapy where you're actually not just doing spots, but you're doing something to treat the damaged area in its entirety. So that usually manifests as its whole face. So in that sense, that I'm doing a fractionated technology, usually a fractionated erbium or fractionated CO2. Those are the two that I like to use. The other option would be a fully ablative laser where you're actually taking all the skin layers down, but it depends on kind of what the downtime looks like for each patient for sure. But either fractionated CO2 or erbium or fully ablative CO2 or erbium. Those would be my top 4 choices as far as treating a field of precancers.
And if they have less downtime, maybe like a 15-15, 19-27 combo?
Yeah.
Do you have sometimes, or do you prefer
I prefer an erbium, but that's just because it's truly ablative, where I know that collagen is vapor rather than just heat damage. If it's somebody who has a darker skin tone or anything like that, then obviously it's safer to do both of those wavelengths for sure.
Yeah, and I think the data supports definitely doing the fractionated more than the non-ablative 15-15, 19-27 combo. But you're right, if there's a downtime issue or, the darker skin tones, that is a nice choice.
Yeah.
But yeah, I completely agree with you. I like the spot for 1 to 5. Erbium CO2, you can really kind of pinpoint it and then get a nice margin too. Decrease your chance of scarring. And then also, once they have a lot, you talk about doing a full face of something fractionated.
Yeah. And I think that's really important because a lot of patients, even some of my medical derm patients, they come in and they say, oh, well, you froze a spot here, but now I have a spot here, here, and here. And that's really because I tell people it's like weeds in the garden. That area has been so sun damaged. And I like to explain to people, it's almost like it's too lazy to do that turnover every 28 days. So instead of doing that, it just makes a little like a scaly spot. And that whole area, whether that be your face or your left cheek or whatever that the case may be for, the particular patient, that whole area has seen the same amount of sun damage. So it's almost like you're chasing weeds if you do that. And if you don't do a field therapy.
Agree. Treating the whole area is always a good idea.
Yeah, I tell people the risk is somewhere between 1 and 10% of each precancer over a year's time. So if you think about it as like a numbers game, if you have 1, it's relatively low, right? But if that becomes 50 or 100, then probably one of those is going to turn into skin cancer, just running the numbers, right? 1 to 10%. So at that point, you do need to do something to address the whole field of where those precancers are coming up.
Yeah, and it's interesting that I found in my practice with treating skin cancer and, precancers, when I did a lot of Mohs cases, was it's almost like the DNA damage, it like accumulates and then it like crosses a threshold. And then the patient has like 1 skin cancer every 6 months for the rest of their life. So it's like if we can catch those patients when they first get, their first 1 or 2 precancer, or, even if they have 5 when they come to us, we can kind of tamper down all that DNA damage, reverse that DNA damage so that, you're not getting cut on every 6 months for the rest of your life, because that is kind of what I see in my patients.
Yeah, I mean, the data supports that too, right? So we do skin checks every 3 months for 2 years after we found your first skin cancer, because the data suggests that we are most likely to find your next skin cancer or your next series of skin cancers in those first 2 years when we found one. Because you can think about the immune system, how it starts to regulate and turn over the skin. It's doing monitoring checks. And at some point, it's like, well, I'm not going to do monitoring checks anymore. And then it just starts, this whole cascade of precancers, skin cancers. And you got to put that train on the tracks as far as this is where you're going. So if we can definitely stop that, earlier on, that's most helpful for sure.
Do you feel like we're going to a place where people won't have skin cancer?
I mean, there are some things, mostly sun damaged skin cancers like squamous cell, basal cell. I think we're going to catch a lot of those earlier, hopefully, but also, we're a lot more educated on what sun damage can do over time. There are some types of skin cancers that are more genetic in nature, like melanoma has a lot more genetic tendencies, and rare things like Merkel cells. I think that there are still going to be skin cancers. I think a lot of the UV driven and the signature marks that we find genetically in basal cell and squamous cell, hopefully those are going to be largely decreased. Do I think that they're going to be gone? No, because I have my staff so goes to the tanning beds. Not that they do now, but they did, so there's still, even though there's a lot of education, there's still a lot of people who like to go to the beach and all those types of things as far as recreational activity. So I don't think we're going to prevent all UV damage.
Yeah. But we can definitely reverse it in patients. I think,
Yeah.
The patient that starts getting one laser a year at age, like even as late as age 30, will they ever get, squamous cell or basal cell? Probably not. I would say probably not, regardless of how much you go to the beach. If you're getting one good laser a year that's treating the DNA damage, you're probably not going to get skin cancer, at least those types.
Yeah. I mean, it'll definitely be a larger decrease in risk for sure. You're optimistic with nothing, but I'll be realistic and say, it'll probably decrease your risk, like very much so. But, I think people who say like my mom and my dad both have skin cancer, then that's a red flag to say, okay, well, you already have this genetic, predisposition to getting even these types of skin cancers. So you need to do something preemptively to stop that train from going on that track. And the only thing we can do that is with lasers for sure.
Yeah, which is really amazing, because if you think about, like, if you told someone with breast cancer in their family, like, hey, we can decrease your chance of getting breast cancer by 99% if you do this one procedure a year with essentially no pain and no downtime, I think everyone would do it. So it's amazing that we have that technology for skin cancer now. So, Dr. Kesty, I have a precancer, or I have 10 precancers. Tell me about laser versus other modalities to treat it.
Yeah, so we have good data to support that a fractional laser that's in ablative capacity, so fractionally ablative laser like CO2 or erbium, those are going to be equally as effective as something like a topical imiquimod or Efudex or 5-fluorouracil, the topical chemotherapy cream, or another type of precancer treatment called PDT, which is using like blue light and red light therapy. But those are equally as effective, as far as like clearance of the AK at 1 year and decrease in whole field cancerization.
So they're just as effective, but you get the added benefit of actually treating the sun damage. So you get less cancer and precancers in the future with the laser.
Yeah, I mean, that's a little bit of a turn on that. But yes, we also have data to support if you get a fractionally ablative laser, your risk of skin cancer or other precancers in the future are decreased, which is really good data to say that that's going to be helpful for your longevity as well.
And tell me about the scarring and how it looks for the patient 3 to 6 months after, the different options for.
Yeah, I mean, cosmetically, your best option is going to be laser, because either with a spot treatment or fractionally ablative laser, there's little to no risk of scar. There's always, a risk if we do a spot treatment and we go past the first layer of the skin, but it's minimized to, especially in our hands, that's going to be very minimal, if any. Where, other modalities like PDT or field cancerization, as far as, topical chemotherapy, you can get a higher risk of skin cancer. And cryotherapy, which is the other type of a thing that we use for precancers, is going to be the highest risk because you see a lot of patients with like white spots from cryotherapy because it's a very imprecise treatment option for precancers.
Yeah, I mean, it's basically just like blowing up the whole skin, whereas lasers are like this ultra precise machine that we go to like the exact depth we want to treat the lesion without leaving any scars.
Right. I mean, the most common treatment that, in office that patients receive is going to be cryotherapy, which is, it's very available. It's relatively quick procedure. It is covered by your insurance. So it's one of the things that people definitely turn to. But over time, it's really not going to be your best cosmetic option. And even preventing skin cancers or precancers in the future, it's not going to have any added benefit of that as well. Okay, so let's go over what the differences is between fractionally ablative, fully ablative, what that looks like as far as pre-cancer and things like that in our clinic.
So I like fully ablative for the spot treatment, and I like fractionally ablative for field treatment, but I also like fully ablative for field treatment. Both of those are fine. I think it depends on the patient's skin tone and skin type. If they can tolerate a fully ablative, that's going to be my preference for the whole face. So you're going to get 10 to 15 years rejuvenation. We're going to treat the precancers, fine lines, wrinkles, all the good stuff about a fully ablative laser, but also you get the treatment of the precancers, decrease your chance of getting skin cancer in the future. So I love fully ablative if they're a candidate. If they don't have the downtime and if they're darker skin tones, then we can do some fractionated laser. So that's going to be 3 to 4 sessions, 1 month apart, 2 to 3 days downtime for that fractionated laser.
Do you feel like there's a difference in efficacy between fully ablative and fractionally ablative? If you did it in like a 1-to-1 ratio?
No, I don't. Not clinically. I think patients do really, really well either way. If someone does 4 fractionally ablative, their chance of getting skin cancer is probably so much decreased compared to if they didn't, and same with fully ablative.
Yeah. I mean, I think if you talk about the science of what fully ablative means, it means you're taking off most of that epidermis where all of the kind of, pre-cancer, skin cancers, they're all coming. The root of all of those are going to be in that epidermis. So you're basically rejuvenating that whole area in the whole field that you're treating. Whereas a fractionating technology, you're really kind of making like columns, but your body is then stimulated to fill that column in with new collagen and things like that. So that decreases. So even if you can think of it as like poking little holes in the precancer, and basically your body will then clear it at that point.
I would say, like, if you just look at the data and you're just reading the papers, fractionated laser has a lot more data on treating precancers, decreasing your chance of skin cancer, just because there are very, very, very few studies on fully ablative and skin cancer. But, from a clinical standpoint, what we see in practice, and then also just if you think through the logic of it, I think they're very, very similar. And now treating skin cancer, which I know we're not talking about, but a lot of the data coming out treating skin cancer is going to be fully ablative. So
yeah, I think that's going to be another episode if you want to tune into that.
But yeah, for sure. I've been to the science.
We'll talk about how to treat skin cancer. But for today, we talked about how to treat precancers, what a precancer is, what lasers we like to use, and whether you're a candidate for, just a spot treatment or field cancerization, and what all that looks like too.
Yeah, thank you so much for all the great information.
Yeah, thanks everyone for tuning in. We'll see you next time.